We are one of the fastest growing pharmaceutical company in India. With a growing presence in more than 80 countries, McLeod's is now gearing to be a pace setter for the world healthcare. And today, we have two eminent speakers with us. The chairperson for today's program would be Dr. Biplab Bandyopadhyaya. Dr. Bandyopadhyaya has done his MBBS in 1983. He's done his MD Medicine in 1987 and done his DM Endocrinology in 1996. He's been practicing as a diabetology and endocrinologist. He's an ex-honorary secretary of the RSSDI Chhattisgarh from 2015 to 2018. He is the president, Arogyam Prevention and Control of Diseases Society from 2006, organized more than 200 diabetes care camps. He has organized the first RSSDI Chhattisgarh chapter conference in 2015. He has published a number of research papers in national, state, and international journals. He has also participated in multiple clinical trials. And today, the speaker for the evening would be Dr. Pankaj Manoria. Dr. Manoria is an interventional cardiologist and director at Manoria Heart Care Center, Bhopal. He has received fellowship from European Society of Cardiology, Society of Cardiac Angiography and Intervention, and also a fellowship of the American College of Cardiology. He also has more than 60 publications in national and international journals. He was the past editorial secretary in the Indian Heart Journal. He is the executive secretary of the API MP chapter, faculty and speaker at various national and international conferences like the Euro PCR, Asia PCR, CSI, API, ICC, NIC, etc. He has received many awards, including President Shankar Dayal Sharma Award, KK Kak Memorial Award, and the Pfizer Medical Award, etc. He has also he has recently written a book in Hindi titled Dil Ka Mamla, which has been very much appreciated. With this, I would like to hand over the session to Dr. Bandyopadhyaya, who would like to do a context setting for the meeting today. Over to you, sir.
Yeah, thank you, Dr. Sanket. Good evening, all participants. Today we will discuss dapagliflozin in a context of two conditions, heart failure and CKD. So despite recent development in various therapies for heart failure remains a leading cause of morbidity and mortality worldwide. In diabetic patient, heart failure chances are 2 to 5 folds higher. Whether one hypoglycemic agent will prevent heart failure, that was a dream and that was a miracle, and that miracle is going to happen. And we have seen in major 3 clinical trials, declared CME 58 trials, empiric outcome trials and canvas trials, we have seen that dapagliflozin and SGLT2 inhibitors can reduce the prevalence of heart failure, can protect it. So SGLT2 inhibitor has come up with a novel therapeutic agent in diabetic as well as non-diabetic population. Second point is CKD. CKD is also the fastest growing mortality factor, and by 2040 it will be the 5th largest cause of mortality. And aging, obesity and hypertension are the leading cause of this CKD, and currently hypertension is the biggest cause of it. And CKD after diabetes, you know that it is very common. The different trials have shown that dapagliflozin is effective in reducing diabetes-related chronic kidney disease. And recently, in non-diabetic chronic kidney disease also, dapagliflozin has been found to be very effective. So many trials are going on. Every year we will know something new about dapagliflozin and SGLT2 inhibitors. And with these 4 words, I hand over and invite Dr. Pankaj to declare his presence and make this program a success. I saw his
Okay.
slides are excellent, and I think it will give enjoyment to the people who are
Okay.
joining. Thank you.
Thank you. Thank you, Dr. Biplab Bandyopadhyaya ji. And I'm thankful to the Macloid people for giving me this opportunity to share my views on this very important and emerging molecule. So thank you, everybody, and welcome all the delegates. Now, we know that heart failure is increasing in epidemic proportions in India. It has been estimated that there has been almost 18 million heart failure patients in India, and this burden of heart failure is increasing day by day. Heart failure is it has been seen, it has been that heart failure is, in fact, it is more malignant, or in fact acts as malignant as many cancer of GI cancers. The mortality of heart failure is almost to the same extent what the mortality we see in various GI cancers. In spite of all the recent advancements, the 5-year mortality of heart failure is still 50%. That is a huge number. And besides mortality, these patients of heart failure do decompensate frequently and lands up into hospitalization for heart failure with acute decompensation off and on, which further deteriorates their prognosis and also pose a financial burden to these patients. So now, with this background, with this, we know that heart failure is a malignant disease, and its prevalence is increasing now. Now we have the medical science has also progressed a lot, and now we have the 5 pillars of treatment of heart failure. And these 5 pillars, I'm saying, because these 5 agents have proven to reduce mortality and reduce hospitalization for heart failure in HFrEF patients. AC inhibitors number 1, ARNI is number 2, beta blockers number 3, MRAs is number 4, and the number 5th agent, which has been recently found to reduce mortality in HFrEF, means heart failure with reduced ejection fraction, and which is the 5th pillar of our treatment for heart failure, is the SGLT2 inhibitor. So SGLT2 inhibitors are the 5th pillar of HFrEF treatment. Now I've designed in on base of question answer session just for a better clearance of all the delegates. So I'll just first ask the question and then we'll discuss. So which patients of HFrEF should receive dapagliflozin? The answer is all the patients of HFrEF who are in NYHA class 2 to 3. That means who are in a heart failure, but they're not decompensated enough. They're not in the NYHA class 4, means they're not hospitalized. Means stable heart failure, ejection fraction less than 40%, NYHA class 2 to 3, all these patients should be on HFrEF patients, even when they are on other pillars of treatment, like even when they are on ARNIs or ARBs, AC inhibitors, beta blockers, and MRA. On top of it, you should all try to add this agent dapagliflozin in this patient, because, and on top of these agents, this dapagliflozin has found to reduce the composite endpoint of cardiovascular mortality and heart failure hospitalization by almost 25%. That is why this should be in the treatment armamentarium of all patients of HFrEF. So why I'm saying that, because there was a very big trial, DAPA-HF trial, which was conducted in almost 5,000 patients. And in this, all those patients of heart failure with low ejection fraction, they were randomized into 2 groups. One, they have given only placebo, and another they given dapagliflozin 10 milligram once daily. And these patients were followed up of almost 16 to 18 months. And what they found was that the primary endpoint, which was the composite of cardiovascular death and heart failure hospitalization, was reduced by almost 25%. So that was a huge number, and the p-value was very much significant. So this all patients of HFrEF, when they were given dapagliflozin, the composite of cardiovascular death and heart failure decompensation was reduced by 25%, and that was a huge number. So that is why, in fact, all the primary endpoints in individual cardiovascular death was reduced by 18%. All-cause mortality was reduced by 17%. Heart failure decompensation was reduced by 30%, and the primary endpoint have failure. So all, not only the primary endpoint, but all, even the mortality, the CV mortality, and all-cause mortality was reduced significantly. That is why we say all patients of HFrEF in today's scenario who are in NYHA class 2 to 3, I'm mentioning 2 to 3 because we have no data that in NYHA class 4, means patients who are hospitalized for heart failure, who are severe heart failure or acute decompensated heart failure, we don't have enough evidence, but for stable heart failure who are in NYHA class 2 to 3, this agent should be a part of your treatment armamentarium. Now, the second question which comes to all of your mind or in everybody's mind, that can we use this diabetic drug in non-diabetic HFrEF patients or not? And the answer is big yes, because in DAPA-HF trial, almost 52% of these patients were non-diabetic patients. So in that group of patients who were non-diabetic also, this agent has shown almost similar benefit. You can see all the benefit was same whether you have diabetes or non-diabetic. That is, the message should be very clear. Even in non-diabetic HFrEF patients, the benefit was almost the same. You can see almost 27% benefit was seen in the non-diabetic and 25% was seen in the diabetic. So almost the same benefit was seen whether you have diabetes or not. Now the next question which comes to our mind, that will it not cause hypoglycemia if used in a non-diabetic HFrEF patients, because these are anti-diabetic drugs? But again, the answer is big no. If you look at the trial, if you dissect the trial based on diabetes or non-diabetic, now you can see here there was, if the major risk was a risk of, just focus on the last second line, there was zero incidence of hypoglycemia in non-diabetic patients also when you go dapagliflozin. And so there was negligible risk of hypoglycemia. So the risk or the concern with all the physicians which have, if you give this drug, will it cause hypoglycemia or not? There was no risk of hypoglycemia, and hypoglycemia was not seen in this trial. Why we don't see hypoglycemia? If you look at the mechanism of action with this drug, this is SGLT2 inhibitors. That means it prevents the absorption of 2 molecules of sodium and 1 molecule of glucose from the proximal converted tubule. But this absorption is prevented only once the glucose comes into the circulation in the PCT. If in a normal individual with a normal glucose level, there was no glucose is excreted from the PCT, that is the proximal converted tubule. So the absorption is not it doesn't prevents the absorption. So it will not cause a glucose excretion from the urine, because the glucose are not coming. Glucose reach the PCT only once the blood glucose is more than 180 milligrams. So the DAPA doesn't act when the blood glucose is less than as in a normal glucose. So it doesn't cause hypoglycemia. So this should be very clear in our mind that there's no risk of hypoglycemia in a normal individual. So now, another concern is there a risk of hyperkalemia, which is seen in with this ARNI? Again, the answer is no. Again, in DAPA-HF trial, even when these patients are on potassium-sparing diuretic, that is the MRAs, that is the mineralocorticoid inhibitors, there was no risk of hypoglycemia. You can see 1.4 in DAPA versus 2.4 with the placebo. So whether you use MRAs or ARNI or not, the hyperkalemia risk is negligible. Now you can ask me what do the guidelines say? Now that this newer drug had been embraced by all the guidelines, I can say if you look at the recent Canadian guidelines of heart failure, they say that they recommend SGLT2 inhibitors such as dapagliflozin in patients with heart failure with reduced ejection fraction less than 40% with or without diabetes. And they have given it a high quality evidence. They strongly recommend this drug to be used in HFrEF patients with or without diabetes. Even the FDA, the US government, the US FDA has approved this new treatment of dapagliflozin in our heart failure patients. And this FDA release came just few months back in May 5th, 2020. So Canadian have proven, American government has embraced this new drug and is given. Even the Europeans are not lagging behind. The European Society of Cardiology have released a position paper of statement of heart failure, and they are saying that dapagliflozin has shown a very tremendous benefit in HFrEF patients, and this should be used in patients with HFrEF with or without diabetes. So I have given you 3 strong recommendations by all these large famous guidelines and famous bodies, which are saying that they should be used, as dapagliflozin should be used in HFrEF patients because it saves life and it saves patients from decompensating and saves heart failure hospitalization in these patients. So now what is the mechanism of benefit? Frankly speaking, if you ask me mechanism benefit, nobody knows the exact mechanism, but there are various theories have been put off that it causes the hemodynamic benefits. We all agree that it causes reduction in the blood pressure, it causes reduction in the body weight, but besides that, it also acts at the molecular level. It acts in the hydrogen exchange mechanisms. So its number of mechanisms has been postulated it at the molecular level, at the hemodynamic level. But what we are concerned more that it acts definitely, it saves our life. That is more important, though the mechanism may not be very clear to us. As I've discussed, it includes a preload, interstitial edema, lots of things had been added. One more point, like it causes diuresis, that is very clear, but it is different. It is quite different from the loop diuretics by number of ways. Number one point of difference in diuresis caused by SGLT2 inhibitors than loop diuretics, it is that it causes reduction in the interstitial volume and not intravascular volume, which we see in loop diuretics. Second difference point with the diuretic is that it doesn't cause reflex sympathetic stimulation, which we see in diuretic. Number three, that hyperuricemia, which is a side effect of these loop diuretics, is not seen with dapagliflozin. So these are three basic differences in the diuresis, which is seen with SGLT2 inhibitors and rather than with the loop diuretics. Now you may say that now we have ARNI also, which have shown in the Paradigm HF trial to reduce mortality and other things by almost 25 to 30%. So so should we use when we are using ARNI? Yes, the answer is yes, because if you look at the DAPA HF trial, and if we see particularly those patients in DAPA HF trial who were already taking ARNI, the benefit was seen on top of ARNI. That means whether you are taking ARNI or not, you see incremental benefit. So it is not a substitution to ARNI. It is an additive effect, and you see the incremental benefit when you use on top of ARNI. So whether you use ARNI or not, the benefit was seen in the DAPA HF trial. Even as I've told you, when you use both the agents, you cause an incremental benefit in your patients. CV mortality reduced further, the heart failure hospitalization reduced further. So you should try to use ARNI as well as DAPA in all your patients. Both these drugs should be used because the benefit is complementary and additive rather than substitutive. Now, we are just two molecules among the SGLT2 inhibitors which have shown very great benefit in HFrEF patients. One which we have discussed, the DAPA in the DAPA HF trial, and other was the EMPA in the EMPEROR reduced trial. So I agree that both these agents have shown us tremendous benefit, but there was slightly difference in both these two agents and in the trial result. If you look at the CV mortality, which was reduced to a larger extent, almost 18% with DAPA HF, whereas it was reduced by only by 8% in the EMPEROR reduced trial. But having said that, I still say that both these agents have shown a similar benefit in the primary endpoint, which was the composite of cardiovascular death and heart failure hospitalization by almost 25%. So both these agents can be used, but the data is still slightly better, I can say, in terms of DAPA, but still both these agents have shown a tremendous benefit in HFrEF patients. And if you look at the test of heterogeneity, almost both these agents don't show any significant test of heterogeneity, and both have shown a very good result. Now, the second point, another point of discussion can be how early if you see the benefit in your patients of HFrEF, you start using DAPA. It has been seen that the benefit was seen as early as within 4 weeks. So if you start this drug, you can see the benefit within 4 weeks because within the 4 weeks, the curve starts to diverge early. So that is why it is said that you should start early this drug, early in the phase of heart failure, because benefit you will see early. So earlier the better. So more early you start, the more early will be the benefit seen with this drug. Now, just to show that if what will happen if we use guideline directed medical therapy in HFrEF, that means if we try to use all the 5 pillars of treatment of HFrEF, the ARNIs or the ARBs, then the beta blockers, MRAs, and SGLT2 inhibitors. A very interesting paper came in the Lancet, in which they have tried to project what can be the projected increase in the survival if you use all these 5 agents. And they came to the conclusion that as compared to the conventional therapy, in which you use 2 to 3 drugs only, whereas if you use a comprehensive therapy, GDMT, that is the guideline directed medical therapy, and try to use all these 4 agents, you improve the life, you add 6.3 more years of life to your patient. So ladies and gentlemen, if you try to use all these five pillars of treatment in HFrEF patients, you can prolong your life of all your patients by almost 6.3 years. That is why it is important to follow this GDM tree, because it improves survival in your patients. Now, another point of discussion can be which agents to be used. We have now Arnian, we have now DAPA. So which agent should you use? I think it depends upon number of factors. It depends upon what is the blood pressure of your patient, what is the volume status, how is the kidney functions, and what is the potassium. I'm saying this because BP reduction is seen to a larger extent with ARNI. So if you are seeing a patient of HFrEF who is having a very low to medium blood pressure around 100, 110 or 100, you may be scared to use ARNI because it causes a hypotension significantly. But blood pressure reduction is not very significant with SGLT2 inhibitors. So in a low blood pressure also, you can use SGLT2 inhibitors. If the patient is hypervolemic, because SGLT2 inhibitors causes more diuresis, this can be used first, then ARNI, they say. If the renal functions are impaired, means sometimes you can see, so it is difficult to use ARNI sometimes, but you can use SGLT2 inhibitors even when the GFR is up to 30. In hyperkalemia is not a risk with SGLT2 inhibitors. It is a risk with ARNI, but hyperkalemia is not a risk with this drug. So this can be, so these all the 5 parameters should be in your mind when you decide which therapy should be started first. But just to I think we can skip this. So just what my approach is, if I'm seeing a wet patient, means who's in hypervolemic, I may start early, I may start once these are dry, or I may add MRAs, and at the end I can use SGLT2 inhibitors. The main point is we have to use these drugs whichever first. It depends upon the individual choice, but in due course of time, all these 4 agents should be the part of the treatment armamentarium in your HFrEF patients. You may use one agent first or second agent first. It depends upon the individual choice and depends upon the volume status, the blood pressure, the hyperkalemia, the renal functions. This is just to highlight this. This used to be the conventional sequence of how we approach to our HFrEF patients. We give ACE inhibitors first. Initially, I'm talking about the decade before. Then they give the beta blockers, and then the mineralocorticoid inhibitors, then ARNIs, and in the end, we used to use SGLT2 inhibitors. But now this is a proposed new sequence. They say you can use beta blockers and SGLT2 start away, then step to ARNI, and then mineralocorticoid and inhibitors. So with this new proposed sequence, all these 4 agents can be used within 4 weeks. Whereas in the left side, the sequence which initially followed, it up to 6 months is required to use all the 4 agents. But again, this should be individualized. There's no hard and fixed. This is just the proposed sequence by various bodies, they have said. Now, what about, as said, in my initial lecture, I've said which patients of HFrEF should be on DAPA, which are stable heart failure, NYJ 2 or 3. But can it be used in HFrEF patient and acute decomposite heart failure? I think we need more data to support this. With HFrEF, I can say the future of SGLT2 is very bright. Various newer evidences are emerging with heart failure, with preserved ejection fraction also. There's a dedicated trial with DAPA, that is a delivered trial, which is ongoing, which is studying only those patients of heart failure who have normal ejection fraction. And they are trying to find out whether this DAPA is useful in that category of patient or not. I think with time, which tell us, but still, I can see I'm very optimistic about the result. And the second category is acute decomposite heart failure. Again, the various studies are still ongoing, but at present, we have data more about stable heart failure, which should be used. In acute decomposite, we have seen that sotagliflozin, which is newer SGLT2 inhibitor, has shown in the SOLIS WHF trial, in which all those patients of acute decompensated heart failure. Once they are stable, they are using an NYHA class 4 also. Yes, we can use in 2, 3, but 4, we need to wait first, but data is strongly emerging. And I'm sure with couple of months or within a year, we'll have much more data strong enough to use these dapagliflozin in acute decompensated heart failure also. Now I've spoken enough about heart failure, and a few slides about the chronic kidney disease also. Now, which we know that CKD is again which is very common in diabetic patients and hypertensive patients also, and which adds to the morbidity and mortality in our patients. So, but so till now we didn't have any drug which can causes protection of the kidney and which can delay the dialysis or which can delay the renal transplant in our patients. The only agents available was the RAS blockade, which was used, but but that also had many limitations. But now, besides RAS blockade, we have a newer agent which has shown a very promising result in kidney protection and delaying dialysis and delaying the renal transplant in CKD patients. That is a dapagliflozin. And why I'm saying that, because we have another. This statement of mine comes from a very large randomized study, that is the DAPA-CKD study, which was a large randomized trial of almost 4,000 patients of chronic kidney disease with or without diabetes. Again, I'm saying with or without diabetes. In that category of patients of chronic kidney disease who had a eGFR between 25 to 75, and these patients of CKD, they were randomized into two categories. One, they were given placebo, another they were given dapagliflozin 10 milligram. And what they looked into for the primary endpoint was a composite of sustained more than 50% reduction in the eGFR and stage kidney disease, renal or CV mortality. So they were looking into renal decompensation and cardiac decompensation and compared with the placebo. And what they found was that the composite endpoint of renal death, cardiovascular death, and stage kidney or a decline in the GFR was much better by almost 40%, 39%, you can see. That's a huge number. In the DAPA-HF, we have seen the endpoint was reduced by 25%. Here, 40%. So the renal benefit was much more exorbitant, which was DAPA, which was seen in this trial. And if you look at the p-value, it is 0.000028. Frankly speaking, I have never seen a trial with such a huge p-value. It's difficult to count the zeros also. So tremendous benefit was seen in this trial. Again, it was a main trial, which was it was the limelight of all the trial in the ESC Congress meeting about few months back only, and it was the most talked about the trial. Again, the primary endpoint was reduced by 39%, and even the mortality was reduced by 31%. And this again was almost 40 to 50% of these patients were non-diabetic. So in non-diabetic patients of CKD also, it has shown a tremendous benefit. So now the next question comes up to what GFR we can use these drugs. If you look up, if you go by trials or evidence-based medicine in the DAPA-CKD, they have included eGFR of 25 to 75. So above 25, we can use it. In the Credence trial with canagliflozin, they have used up from 30 to 90. In DAPA-HF 30, in Emperor-Reduce, almost 20, they have used this drug. So this is the cutoff limit of all these trials in which they have used this drug. Now, if you look at these composite endpoints of various trials, not only the DAPA-CKD, all these trials with the Emperor, the Canvas, the Declare-TIMI, the Credence, the Vertige, all these agents have shown renal protection. I think the renal benefit is a class effect with all these SGLT2 inhibitors. All have shown almost 25 to 40% reduction in the renal composite endpoint. So I can say this SGLT2 inhibitor is a boon for our CKD patients, because we have very limited treatment available for these CKD patients to reduce their progression. Again, there's a very important, very beautiful slide in which they have tried to project that how much we can delay the dialysis if we use these SGLT2 inhibitors. And they came to the conclusion that if we use SGLT2 inhibitors, dapagliflozin or any, for the matter of fact, any SGLT inhibitor, you can delay the dialysis by almost 10 years. I think this is all we want in our CKD patients. All a CKD patient want is to not to land up into dialysis. And if you use this drug in a proper time, at a proper time, you can delay the dialysis by almost 10 years, as seen by these various evidences. Now, this again, and this drug for CKD patients had been embraced by various associations. The European Association of Diabetes, American Diabetic Association, and ESC, they have said that you can use in diabetes patients with CKD. It can be used with this drug to prevent CKD progression. And now very recently, I think almost 2 to 3 days back only, this dapagliflozin has been approved by DCGI for chronic kidney disease usage also in India also. That's a very good, and I must congratulate everybody for this. And so if you just summarize the benefit of dapagliflozin in the three category of patients, we have three large trials. The DECLARE trial was done in patients with diabetes, with atherosclerotic cardiovascular disease or multiple risk factors, in which it has shown that the primary endpoint of CV mortality in HF was reduced. In DAPA-HF, we have shown almost a 25% reduction in the CV mortality and heart failure hospitalization. And DAPA-CKD also, we have shown a tremendous benefit. So three category of patients: diabetic with ASCVD, HFrEF patients, and CKD patients. So all the three category of patients, this molecule has shown a significant benefit. So just I end up this slide in just a very beautiful statement by the Professor Zoller has said that SGLT2 inhibitors once started with diabetics as anti-diabetic drugs, and now they belong to cardiologists and nephrologists, because benefit in cardiology and nephrology has been exorbitant, much beyond just the anti-hyperglycemic benefit which we see with the other drugs. Thank you very much, and greetings from Bhopal, the city of lakes.
Thank you, Dr. Pankaj, for excellent presentation and justifying the use of an anti-diabetic drug, dapagliflozin, for use in heart failure and kidney problems. So it is an excellent presentation, and we know that about 2/3 of our patients who are in diabetic clinic are having some or other cardiac problems, and about 10 to 40% of our type 2 diabetes mellitus patients have got some element of the renal failure. About 30% of the type 1 diabetes mellitus do have also renal problems. And so the trials are ongoing for type 1 diabetes, for type 2 diabetes, and also for non-diabetic population to see the benefit of dapagliflozin. And newer drugs like finerenone, which is coming for CKD, is also will be discussed in context with the dapagliflozin, and nicely said by Dr. Pankaj that it is basically a diabetic drug, and now it is going to be owned by the nephrologist and a cardiologist first. Yeah, Dr. Manoria is a cardiologist and the nephrologist. So it remains a drug for the physician, and I think it will remain a drug for the physician, and whosoever uses it judiciously should give benefit to the patients. Thank you, Dr. Pankaj. Over to Sanket. You are mute.
So thank you, sir, for the excellent session. I'm sure the attendees would have gained deep insights after listening to the session, as well as the context setting, sir. I thank both the speakers today, Dr. Biplab as well as Dr. Manoria, sir, for the excellent session. If there are any questions, I would. So we have our first question, sir, coming from Mr. Amit Sahu, who wishes to ask you: can dapagliflozin be used in stage 4 and 5 CKD patients?
I think we have evidence up till 25 eGFR. Below that, if the GFR is less than 25, I think it is not recommended to use, because in DAPA-CKD they have included above 25 to 75 GFR. In the Credence trial with canagliflozin, they have included up to 30 GFR. So I think if the GFR is below 25, it is. I think it's not advisable at present to use this drug, because they can cause an acute kidney injury in that patients. Otherwise, if the GFR is above 25, I think we can use this drug.
Thank you, sir. We have Dr. Mane, who wants to congratulate you for the excellent presentation, sir.
Thank you. Dr. Bandyopadhyaya, what are your use in non-diabetic patients? I hope you are
Yeah.
convinced. You are
So,
convinced or not?
since we are using it in diabetic patients,
Uh,
so if I catch hold of any non-diabetic patient with heart
yes,
failure
heart failure.
and CKD, and then I will not refer to cardiologist or nephrologist. I will use
Yeah,
it myself.
yeah, it's very good. Yeah,
No, I will not do it. I don't
yeah,
enter to the arena of other super specialists. I don't do
yeah.
it, and I refer the patient to the right person when
Exactly.
the serum creatinine is more than 2, as it is advised by the Endocrine Society of India. We should refer
Yeah,
to, and whenever there is a heart failure, which is quite significant, then definitely I should refer this patient to a cardiologist. And
yeah, yeah.
that is a genuine practice, what we should do.
Yeah, yeah. And we should not be scared of hypoglycemia, because
Yeah,
hypoglycemia
yeah,
doesn't happen with this in the normal glucose level in normoglycemic
yeah, yeah.
patients,
But I
because the
want to also,
pathogenesis of hypoglycemia is different. Once there's hypoglycemia only, then only the glucose is going to get excreted from the PCT, and that is then only the absorption is will be inhibited by SGLT2 inhibitors. In a normal glucose, it's not going to cause hypoglycemia. So we should
yeah,
not be scared.
that's why I was remembering a few of my poor patient who really cannot go to the other and don't want to go to others and have got a creatinine of 2.43, and they are happy with an antihypertensive and of AC inhibitor or ARB. Whether to those patients I can use the drug, but my fear is as soon as I will use this anti-diabetic drug, the patient will run off from my clinic because he will know that it is an anti-diabetic drug. So that is my fear.
That is why I think proper education among the physicians and
Yes.
everybody is very much required,
And patient's
because
education is,
it has been imposed in everybody's mind that it's a anti-diabetic drug only.
yes,
We need to
yes.
understand it is a multi-spectrum drug. We have seen benefit in
True,
NAFLD
true,
also. We have seen benefit in
true,
OSA
true.
also. We have seen benefit in resistant hypertension also. It's a drug for everybody.
True,
Like
true.
glucose lowering is just a effect, just a
Yes, yes,
byproduct of
yes.
this drug. It is not just the main action. We need to understand. Those started with anti-diabetic drugs, but I think it's mainly a nephrology or a cardiologist drug. I think so.
Yeah, because one of the trial is going on in obesity also.
Exactly.
And non-diabetic obesity also one trial is
Exactly.
going on,
Exactly.
and this is a phase 4 trial. By July 2021, we may be able to
Yeah.
get
And
the
the risk of in the DAPA HF, the risk of hypoglycemia is almost 0% non-diabetic. There was
that
hardly
is
any
true.
hypoglycemia.
That is true. That is true. But
This
it
should
is very
give
important to
confidence in
convince
other,
the
in everybody's mind.
patients. Patients are also needs to be educated about it. True.
Yeah, yeah. But there are few checklists which we need to understand. We should maintain the hydration proper. We should maintain the genitourinary, everything, that hygiene should be maintained, the hydration should be maintained, and we must, it can cause some diuresis. We must educate our patients also. And
I
we
need
must be
one.
very, but and having said that, we must be careful in a very elderly group of individuals when we use this drug, because sometimes this can cause postural hypertension in this drug. So we should be slightly
Yeah,
cautious in
but
very
recently
elderly.
has been established in elderly people also.
Yeah,
But
yeah, but yeah,
up to
I do use, but
75 years.
I make them conscious, because I make them
Yeah,
conscious that they may not cause of sometimes postural hypertension can occur initially, but it
yes.
can be used.
Up to 75 years of age, it is safe. Yeah, true.
Yeah, safe. Any more theories or doubt?
So talking about Indian context, it is
Yeah,
very common to use a combination drugs. So the first combination that looks in for is along with metformin. I'm sure the positioning is quite clear. You start metformin and then you start
yeah,
dapagliflozin.
yeah.
But the confusion that lies in most of the doctors' mind is, shall we have the metformin IR, I mean immediate release, or an extended release? So how and where would you position an immediate release and an extended release with dapagliflozin?
Dr. Upadhyay will, I think.
Yeah, yeah, Dr. Sanket, you are yeah little deviating today's discussion between the immediate and sustained release preparations. So I think that discussion is don't have a relevant part in discussing this scenario. And so we have used immediate release SGLT2 inhibitor with metformin with good result. We have used sustained release metformin with dapagliflozin with good result. And nowhere evidence is available to compare between sustained release and immediate release. metformin plus SGLT2 inhibitor and comparing the two. Research has to be done, and I think Dr. Neville, you can lead it. Yeah.
Thank you, sir. So we have another question coming from Dr. MC Agarwal, who wants to ask, what is your experience of dapagliflozin in valvular heart diseases?
I think in valvular heart disease, I think we don't have any evidences. So at present, I think I don't recommend to use in valvular heart disease with heart failure, because these patients were excluded in all these trials, any valvular heart disease significant. So at least I think now we should not use it in valvular heart disease at present. I think so. I won't be using it.
Thank you, sir. Sir, another question from the answers that you were providing, sir, where you mentioned about weight. So, liraglutide recently has been approved for weight reduction in adolescents also.
Yeah.
And now SGLT2 being approved, or rather the study which showed that the hepatic fat accumulation
Fibrosis and
has and the fibrosis as well has reduced big time when it comes to SGLT2, and the adiposity around the subcutaneous region was accordingly less reduced. So, what is your take, sir, when it comes to this trial? What do you think would be the future that we would be looking at when it comes to SGLT2 and weight reduction?
I think liraglutide has a more powerful weight reducing property. In fact, the USA FDA has approved it as an anti-obesity drug also. For any drug to be get an approval for an anti-obesity, it should cause a weight reduction of almost more than 5% of the body weight. If you look at the reduction in the body weight with liraglutide is almost 5 to 8%, and whereas with this SGLT2 inhibitors cause a 2 to 3% reduction. So weight reduction is there, but it's not that of that magnitude to be used at right now as an anti-obesity drug. So nobody use it, but I think there is ongoing trial. They have said, let's see for the trial, but still I think it's not been recommended. The magnitude of benefit or magnitude of weight reduction is not that extent to that of liraglutide, I can say. And regarding reduction in the hepatic fat, yes, there was one trial, I'm forgetting the name, in which was done in NAFLD patients and NASH patients, and which they have found that it caused reversal of the hepatic fibrosis. Again, that is a very welcome indication and welcome benefit of this, because again, we don't have any drug for NAFLD, which can reverse NAFLD. I think gastroenterologists will again be very excited with this drug, because this has caused a reduction in the hepatic fibrosis. Though it was a very small trial of almost, I think, 150 patients. But still, I think the mechanism is there, and we need more data, but still, I think it's a very promising, promising effect of this drug.
Thank you, sir. We have Dr. Amit Sahu who wants to congratulate you for the excellent presentation, sir.
Thank you.
So I think there are no more questions, and we have reached the end of the presentation and a good question and answer session. So I would like to officially close the meeting, sir. I would like to thank both the speakers for being wonderful and enlightening session. And I'm sure the listeners would have gained deep insights in managing patients better using the learnings from your session. So we at Macleods would like to honor your vast experience and your kind heart to share the same on such a platform for the benefit of all the current and the future listeners. Sir.
Thank you.
I, Dr. Sanket Niwale, representing medical team at Macleods Pharmaceuticals, on behalf of the marketing and the sales team, I want to thank you for supporting us in this scientific endeavor, and I wish you a great evening ahead, sir. Thank you.
Thank you, Dr. Upadhyaya.
Thanks very much.
Sanket, and thank you all the delegates.
Thanks all.
Thank you.
Thank you.
Bye.
Bye.
Thank you, sir. So I'm ending this meeting now. Thank you.
Yeah, thank you, ma'am.
Thank you.